Thank you for the kind introductions and invitation to speak in AOEC. This is my topics today, how to manage newly diagnosed epilepsy in adults. I have no disclosure. This is the outline of my topics today, and you can see that the first point has been discussed by Dr. John Dunn in his first lecture, and the last point will be discussed by Hiroshi Shigeto from Japan. However, I would like to add one point related to non-epileptic seizures. As you can see that convulsive syncope is rather a common differential diagnosis in first seizure clinic. Technically, it is very difficult to differentiate whether the convulsions is due to syncope or due to epileptic seizures. And therefore, it is important to look for the syncopal prodromes, including giddiness, sweating, blackout prior to the convulsions, or change of posture as well. And most often, the recovery after the syncope will be quick. You can listen for more information in Dr. John Dunn's talk. I would like to go to the second topics now, which is on the definitions of epilepsy. A 30-year-old man with first unprovoked generalized tonic-clonic seizures, and clinically there is no focal musical deficits. His CT brain biochemistry screening and EEG were all normal. So what will be your diagnosis? Would you diagnose this patient as having epilepsy or first seizures? And is he allowed to drive? By 2014 ILE definitions, we know that for those with two or unprovoked seizures occurring more than 24 hours apart, we can define these patients as having epilepsy. This is similar to the definition in the past. However, for one unprovoked seizures, if the recurrent risk is 60% or more, then they are also can be defined as having epilepsy. So how are we going to identify or determine the recurrence rate of 60%? In this paper in 2013, on the y-axis, this is the cumulative probability of second seizures. And 0.6 over here means that the patient having 60% chance of having recurrent seizures or second seizures. And the 60% point is at 12 months durations. Therefore, for those with remote symptomatic cause, the likelihood of recurrence will be about 60% at 12 months, and therefore, this patient should be classified or defined as epilepsy. How about those with 2 or 3 seizures? As you can see in these plots, for those with second seizures, the chance of recurrence at 12 months is also about 60%, which is over here. Therefore, if someone having recurrent seizures or having 2 or more seizures, that should be defined or diagnosed as epilepsy as mentioned in the definitions. However, for those who has no seizure in the first years, the likelihood of recurrence is actually very low. As you can see in this chart, for those with the recurrence rate or recurrent risk at 1 year is about 30%. But if someone is seizure-free at 1 year, the likelihood of having another seizure within the next 5 years is actually about 10 to 20% only. So the recurrence risk is actually highest in the first or second year after the first seizures, and the risk is about 21 to 45%, and it is greatest in the first years. And therefore, for those with first seizures, I will normally follow up them for at least a year or ask them to come back if the seizures recur. How about driving? Under DVLA, which is Driver and Vehicle Licensing Agency in UK, the driving rules and regulations are as such. For those with first unprovoked seizure or provoked seizures here, we can see that they have to cease driving for 6 months. Whereas for epilepsy, they have to stop driving for 12 months. But what is isolated seizures or first unprovoked seizures? By definition, isolated seizures are one or more unprovoked seizures within a 24 hours period. Therefore, if someone having a seizure in the morning and another seizure in the afternoon, they are still considered as having isolated seizure, but not epilepsy, and they have to stop driving for only 6 months. Whereas for provoked seizures, please note that under DVLA definitions, it includes convulsive syncope due to cardiovascular cause. As we have discussed just now, convulsive syncope is a non-epileptic event, but it is defined as provoked seizures in DVLA, and the patient have to stop driving for 6 months. Other causes of provoked seizures, including structural causes such as stroke, bleeding, or electrolyte or biochemical disturbance, or alcohol or drugs withdrawal. This we can group them as acute symptomatic seizures except convulsive syncope. How about those with underlying causative factors? We usually call this remote symptomatic, and if there is, for example, having a stroke 3 months ago or having an intracranial bleed 1 year ago, then we should classify them as epilepsy or stop driving for at least 12 months. Now I would like to go to the classification of seizure types into focal and generalized seizures. Why is it important to differentiate generalized and focal seizures? Firstly, the etiology will be different. In generalized seizures, is mainly genetic and metabolic causes, sometimes infective causes, whereas for focal epilepsy, the etiology are usually structural. Second point in differentiating generalized and focal seizures will be seizure aggravation or the use of anti-epileptic drugs. In generalized epilepsy, most often we use sodium valproate or those with broad spectrum anti-epileptic mechanisms. Whereas in focal seizures, we use carbamazepine or those with specifically indicated for focal seizures. And we know that for those with myoclonic and absence seizures, carbamazepine and phenytoin can aggravate these types of seizures. And secondly, on the responsiveness to the anti-epileptic drugs, we know that for those with focal seizures, the responsiveness is much lower, and about 30 to 40% will be refractory. And therefore, it is important to differentiate the types of seizures in order to prognosticate the patients as to choose, and as well as to choose which anti-epileptic drugs to use. In addition, it also helps us to identify or plan investigations to identify the underlying cause. In this 2017 classification of seizure types, there are certain features or certain types of seizures which will help us to point towards focal onset. The first one will be automatisms. Automatisms can be either limb automatisms or oral automatisms, or complex automatisms that usually suggest a focal onset. Hyperkinetic seizures are usually frontal lobe in origins, whereas if there is aura, especially cognitive, emotional, sensory aura, this will point towards focal onset as well. The last point will be a focal or asymmetrical presentations of either motor manifestations. For example, focal tonic seizures of the right arm or focal clonic jerks of the right arm and legs. This will be suggestive of focal onset, and asymmetrical dystonia, dystonic posturing will also suggesting a focal onset as well. Therefore, for someone with generalized tonic-clonic seizure and we have no weakness on the ictal onset, then we know that this could be focal or generalized in seizure types. And there are a few tips which will help us to decide whether this is more likely to be focal or not. The first one will be aura. So as we can see in the AOEC table just now, if someone having a non-motor onset or aura, then this is suggestive for focal seizures. If there is asymmetry in presentations, especially head and eye versions or limb automatisms or asymmetric dystonia or hyperkinetic seizures, then they are also likely to be focal onset. Post-ictally, if there is a focal thoughts paralysis or dysphasia, or when we examine the patient and we found focal neurological deficits and neuroimaging focal abnormality, especially in the CT scan or MRI, or in EEG, we have focal epileptiform discharges, then these are also suggestive of focal onset. For those with age of onset more than 20, most often generalized tonic-clonic seizure in these patients, especially if they are unprovoked, they are also likely to be focal because most generalized epilepsy have an age of onset less than 20 years old. So this is a multiple choice questions MCQ. A 20 years old female was witnessed to have generalized tonic-clonic seizures and tongue biting with post-ictal drowsiness. However, the onset of seizures was not witnessed. We are unsure whether this is a focal seizure or a generalized seizure. So, A, can we conclude that this must be a generalized seizure? Answer is no, we cannot if there is no witnessed ictal onset. However, B, if there is family history of epilepsy, especially those with generalized seizures, if the seizures onset is at the teenage age, for example, 17, 16 years old, then this could be a generalized epilepsy, for example, juvenile myoclonic epilepsy. Especially on further questioning, we found that patients have myoclonic jerks in the early morning. This will be even more confirmative. C, if there is a history of aura, and as I mentioned, aura is suggestive or supportive of a focal onset, then it is unlikely to be a generalized seizure. Therefore, C will be wrong. D, on further questioning, the witness described left arm flexions and right arm extension. This is asymmetric curve presentations. Then we know that this is also likely to be focal epilepsy. E, it is impossible to determine the seizure types, which is also wrong, because if we have the EEG, we have the neuroimaging findings, or if we found focal neurological deficits, then this will be helpful as well. Therefore, the most correct answers in this MCQ will be B. Now we come to the next step, which is determinations of etiology. And this is important in managing the patients. For seizures, especially first seizures, we can classify them either as a first or acute symptomatic seizures, or in DVLA, it was defined as provoked seizures. Then we would have to look for the acute causes and manage accordingly. Whereas if someone having unprovoked seizures with a remote cause or recurrent unprovoked seizures, then we will define them as epilepsy. For provoked seizures, the causes can be structural, especially within 7 days of insults. It can be infections, can be metabolic or toxic. Causes can be immune in origin or can be others like febrile seizures or eclampsia. Then we will manage according to the underlying cause. Therefore, in IOEE 2017 epilepsy classifications, we can see that there are 6 etiology listed here, which include structural, genetic, infections, metabolic, immune, and unknown. Some of these can be acute symptomatics, and the patient may not have recurrence after that. And some of them will be likely to have recurrence. For example, brain tumor. Brain tumor is unlikely to be just acute symptomatic. They are most likely to cause recurrent seizures unless the seizures occur during resection or excisions of the brain tumor, and these are surgical related. Second is the genetic cause. If someone having genetic epilepsy, then the diagnosis is also likely epilepsy rather than just acute symptomatic seizures. So let's go to another questions. Is it acute symptomatic seizures or epilepsy? A 60-year-old man presented first seizures and thoughts paralysis, and the CT scan showed an old MCA infarct. So is this an epilepsy? What is the likelihood of recurrence, and do you want to start AEDs? We know that the diagnosis is epilepsy because this the MCA infarct is a remote symptomatic cause. So in fact, in 2005, epilepsy is defined as a disorder of the brain characterized by an enduring predispositions. For example, in this patient with a stroke many months ago or years ago, and is likely to cause recurrent seizures, then we will call this stroke as an enduring predispositions. And even with one seizures, it is enough for us to diagnose this lady as having epilepsy. And I will go back to this 2014 definition again, with which highlight the 60% recurrence risk based on the remote symptomatic cause, and therefore it should be also fulfill the diagnosis of the definitions criteria of epilepsy. For acute symptomatic seizures, most often when someone comes to emergency with seizures, we will always look for underlying acute symptomatic explanation, especially the non-structural one. This includes electrolyte and metabolic screening, the toxic screening if there is a suspicion of toxic overdose, and infections and autoimmune screening based on history. For certain patients, especially those having trauma or focal neurological deficits or having fever, we will do a CT scan at the emergency department. MRI are not commonly done for every patient, and sometimes the waiting time is long, and EEGs are mostly done as outpatients. So what is the indication for a CT scan? Shall we do a scan or new imaging for everyone with first seizures? Answer is no. We can select those with focal features during seizures, which suggests that there might be a focal structural lesions that can be picked up by a CT scan. However, if we can't find a focal neurological deficits, MRI is usually more sensitive. And mostly for those with normal CT brain, MRI may pick up some abnormal findings. Secondly, if someone having a focal deficits like suggestive of a stroke or a bleed or a tumor, then a CT scan is indicated. Thirdly, if someone having signs of raised ICP or meningisms, then we will do a CT scan as well. The fifth point will be regarding treatment. Shall we start anti-epileptic drugs or shall we wait? This is a conjoint decisions between the physicians and the patients. As we know that first seizures having recurrence in about 30 to 70% over 5 years. And immediate treatments will not improve the long-term remission rate. So we should consider anti-epileptic drugs if we think that the risk of recurrence is high. And in 2014 definition, we use the risk as high as 60%. So firstly, if someone having underlying structural lesions, especially the lesions is more than a month ago, if someone having abnormal EEG findings, or someone with positive family history, and second seizures, nocturnal seizures, or cognitive developmental disability, then we know that the likelihood of recurrence is high. The reason why we include nocturnal seizures is because we are unable to be certain of the seizure frequency. Those the patient may present claiming that this is the first seizures. The patient may have previous seizures which was unnoticed in sleep. However, usually I will discuss with my patients regarding the need of having anti-epileptic drugs, the likelihood of recurrence, and the impact on the quality of life. And most patients will consider to wait for the second seizure if they don't want to continue or to take anti-epileptic drugs for at least for the next 1 or 2 years. However, someone may concern about the risk and injury of recurrent seizures that doesn't want to have the seizures in front of the public, then they will consider starting treatment as early as possible. So based on AAN guideline, it is a moderate risk to start anti-epileptic drugs in preventing or reduce the risk of seizure recurrence in the next 2 years. And the level of evidence will be level B. However, in terms of quality of life, the evidence to support an improvement of quality of life is very weak. It's only level C, which means that starting treatment immediately after a first seizures will not affect the quality of life very much. So this is a systematic review done in 2017, looking at the seizure recurrence in those with first seizures and the reported recurrence risk in different cohorts range from 26, the lowest is 26, or as high as 71% having recurrence risk. And from here, we understand that the risk depends on the populations and the underlying cause, and not everyone will have to start anti-epileptic drugs based on this recurrence risk. The last point will be on which AED to choose. Although I know that these topics will be covered by Hiroshi in his next lecture, but I will talk a little bit on HLA-B1502, which is common in the South China and Taiwan, as well as in Southeast Asia, and not that common in Japan. HLA-B1502 and carbamazepine-related Stevens-Johnson was reported by Dr. Chung from Taiwan in 2004 in Nature. He found that all the patients with carbamazepine-related Stevens-Johnson had the positive HLA-B1502 allele. And this was replicated in other countries, including Thailand, in Malaysia, especially the Indian populations, in Vietnam, and this is in Malaysian, Malay, and Chinese as well. And we found that we also have HLA-A3101, but these are more common in other populations like Japan and Korean or India. We also found the associations in Indonesia and Myanmar. In fact, the prevalence of HLA-B1502 is rather high in the South China, as highlighted by the green area over here, which include Taiwan, South China, Thailand, Vietnam, Myanmar, Indonesia, and Malaysia. And it's not that common in the other parts of the world. Therefore, in my practice, in a first clinic consultation, when someone presented with a first seizures, and if I suspect a focal seizures, and I may want to use carbamazepine as a treatment of choice, Then beside sending the patients for EEG and MRI brain, I will also take their bloods for HLA-B1502 screening. So by the time when they come back for a second clinic review for their EEG and MRI results, I would have the HLA-B1502 result as well. I will start carbamazepine only if their HLA-B1502 is negative and the patients agree to consider treatment. However, if the screening is positive, I would avoid carbamazepine but use other anti-epileptic drugs. In conclusion, this is what I have covered. I have covered from differentiating between epileptic and non-epileptic seizures, which has been covered majority by John Dunn. First, seizures and epilepsy diagnosis, focal and generalized seizures in seizure types, how to determine the etiology and the impact of knowing the etiology, whether to start anti-epileptic drugs or wait, and which anti-epileptic drugs to use, especially for those with focal seizures and HLA-B1502 positive. I would like to thank you for listening to my talk.